Welcome to Baptist Medical News Network. I'm Rhonda McRae. Thank you so much for joining us today for our webcast. Our topic today is FAQs, or frequently asked questions about hysterectomy. And so to help us today, we have Dr. John Wooley. Dr. Wooley, thank you for joining us today. Dr. Wooley is an OBGYN with the Women's Clinic. So let's just jump right in. Dr. Wooley, hysterectomy is a very common procedure. A lot of women have to have it, and so there are, I'm sure, a lot of questions that you do hear over and over again. But let's just start with the basic. What is a hysterectomy?
Rhonda, hysterectomy is the surgical removal of the uterus. And I think it's really important to understand the terminology, because if you ask the layperson what is a total hysterectomy, in their minds they think it's removing the uterus as well as the tubes and ovaries, but actually the word hysterectomy just refers to the uterus alone.
Okay. All right. So a big question I think for a lot of women is if they're still having their period at the time that they have a hysterectomy, they're going to possibly have some menopausal symptoms. So tell us about that.
Well, removing the uterus alone, just a hysterectomy, is going to do away with menstrual periods and bleeding. But when you're talking about menopausal symptoms, that's really related to ovarian function. So if the ovaries are removed and no hormonal replacement is initiated, then a woman may well have menopausal symptoms. But the ovaries are not always removed. It depends on the patient's age and the indication for the surgery.
Okay, so that's a discussion that she has with her doctor, and he makes a recommendation.
Absolutely.
Okay. So if she does have her ovaries removed at the time of the hysterectomy, starts having the menopausal symptoms, hormone replacement therapy, is that the usual, or again, is that something that she needs to discuss with her doctor? And the other thing is, if she does go on the hormone replacement therapy, is she on the hormones for the rest of her life?
Again, it depends on the indication for the surgery to begin with. If it's some type of malignancy of the uterus, perhaps hormones may be contraindicated. Also depends on the age of the patient. If you have a young premenopausal patient who undergoes a total hysterectomy, generally we do initiate some type of hormone replacement therapy, but not necessarily forever. The indication or the recommendation for hormone replacement therapy now tends to be to use the lowest dose possible for the shortest period of time as possible. Generally, in a young patient, we might continue that up until the age of the natural menopause, which is around 50 or 51.
Okay. All right. Well, and you've already said after hysterectomy, there's no more bleeding. So if a woman has gone through hysterectomy and experiences bleeding, that's unusual. She should see her doctor.
Well, eventually after a hysterectomy, all bleeding will stop. But in the initial postoperative 4 to 8 weeks afterwards, it's not uncommon to have some vaginal bleeding.
Okay.
But all the problematic heavy periods or severe menstrual cramps that are associated with the indication for the hysterectomy will be resolved. If a year after a hysterectomy a woman has any bleeding, then she would need to see her physician about that.
Okay. Well, you've talked about the surgery. And I know there are a couple of different ways it can be done. Is that correct?
That is correct.
Okay, so why don't you talk to us about the different methods for doing a hysterectomy?
Okay. Well, historically, the most common procedure in the past was a total abdominal hysterectomy. A fairly large abdominal incision is made, and the approach goes through the abdomen. Vaginal hysterectomy is another very common approach. And more recently, there have been procedures where we use laparoscopy, which is a procedure where we make small incisions on the abdomen and put video instruments inside these small incisions to assist in a vaginal hysterectomy. And to complicate things even more, there are now what we call robot-assisted laparoscopic hysterectomies, and there are also supracervical hysterectomies, where the cervix or the mouth of the womb is left intact and the rest of the fundus or the rest of the uterus is removed.
All right, so how does a woman know which of those techniques is best for her?
Well, again, it really relies on several things. Number one, what's the indication for the hysterectomy in the first place? The most common indications are uterine fibroids, abnormal bleeding, pelvic pain issues, which may be related to endometriosis or previous pelvic infection, and then abnormal pap smears or precancerous or cancerous conditions of the uterus. So first of all, what's the pathology? Is there any concern about there being extrauterine disease? For instance, if there's severe adhesions or severe endometriosis involving the tubes and ovaries, then to do a straightforward vaginal hysterectomy may not be the best choice. So I think it's important that patients be aware of all the different approaches that are out there, and also it depends on the expertise of their surgeon. Every surgeon is going to have probably one procedure that he or she may be more experienced in when you are talking about the more advanced laparoscopic procedures. I think all well-trained gynecologists are very familiar with abdominal hysterectomy, straightforward vaginal hysterectomy, laparoscopic assisted vaginal hysterectomy, total laparoscopic hysterectomy, robot assisted total laparoscopic hysterectomy. These are all things that are relatively new. I say that over the past 5-10 years. And so each surgeon may have a preference and may have more experience in one procedure than another.
So it's a good thing for a woman to ask her doctor, how many of these have you done, or
Right.
what is your most common method? Just
Right.
good information to have.
It is, and when you're talking about the more minimally invasive type of hysterectomies, the real advantage is minimally invasive means smaller incisions, quicker recovery, hopefully fewer side effects. As a general rule, a vaginal hysterectomy generally has a slightly lower complication rate than abdominal hysterectomy, a little bit shorter hospital stay, and also quicker back to work. So all of these issues are really important when you're trying to decide what approach to take.
Well, let's talk about recovery from the different types. So just the abdominal technique, sort of traditional technique, what is the sort of expected stay in the hospital, pain, return to work? Talk about the recovery for a traditional procedure.
For a traditional abdominal hysterectomy, the length of stay generally is 2 to 3 days in the hospital, and historically it's been approximately 6 weeks, 6 to 8 weeks off of work. If you think about it, when you're doing a abdominal hysterectomy, you have a abdominal incision, and then you always have an incision at the apex of the vagina where the cervix is attached. Whether you have any of these hysterectomies, there's always an incision there. So if you can eliminate the abdominal incision, it's just one less wound to heal. The body has to heal, and it takes time. No matter how you approach it, the body can only heal so fast. But obviously, if you have smaller incisions, less trauma to the body, then you're going to have a quicker recovery. So generally 2 or 3 days in the hospital for abdominal hysterectomy, generally 1 to 2 days in the hospital for a standard vaginal hysterectomy, and with a laparoscopic total hysterectomy, whether it be straight stick laparoscopy or robot assisted, generally people are out of the hospital in 23 hours to 1 day.
Okay, all right. And talking about returning to work, another question women may have is how hysterectomy might affect their sexual function.
Actually, in the past, there were some concerns about hysterectomy and a supracervical hysterectomy leaving the cervix intact. There were some women who thought that that might improve sexual function or actually help with postoperative incontinence or pelvic support problems, but the scientific studies have not really supported that. When you're talking about sexual function, most women in most of the scientific studies actually have improved sexual function. If you think about the indication for hysterectomy for most women, whether it be abnormal bleeding or excessive bleeding or bleeding all the time or pain associated with intercourse, once they have the hysterectomy and that problem is relieved, actually it opens up a whole new window for them. And so actually sexual satisfaction in most studies has improved.
That's a good fear relieved, I'm sure, for a lot of women. So normal exercise and activities, again, return to that just depends on the technique, but
it does
allow time for healing in either case.
Right. Even with the most minimally invasive surgery, the vaginal cuff has to heal, and so generally we refrain from any type of sexual activity for at least 6 to 8 weeks after the surgery to allow that area to heal. Mm-hmm. And so no vigorous exercise as a general rule. You always read about occasionally somebody that's out running the marathon 2 weeks after a hysterectomy, but I'm a little skeptical of some of that.
All right. So talking about recovery and just long-term effects, could this have an effect on a woman's health otherwise? Say, can it affect her heart health or make her more at risk for other illnesses like osteoporosis?
Again, it comes back to not so much removing the uterus. When you remove the uterus, obviously your fertility or your childbearing years are over. Number two, you're not likely to have cervical or uterine cancer. And obviously any kind of problematic menstrual periods are going to be over. I think it's important when you're talking about fertility or childbearing issues, when you talk about post-operative mood or post-operative satisfaction, obviously if you're having problematic periods, if you have a hysterectomy, if you do away with the problematic periods, you're likely to be very pleased. If you are an infertility patient who has severe endometriosis and has to have a hysterectomy for that, there may be some other psychosocial issues or psychosomatic issues that you have to deal with just because of the loss of fertility. So those are major issues when you're counseling patients preoperatively. You know, people's satisfaction with their surgery depends on, you know, what's the indication in the first place.
Well, another thing, talking about the post-operative period, how common are complications after the surgery? And say a woman is at home, what sort of things should she be looking for when she should call her doctor? This doesn't feel right.
Well, the complication rate with hysterectomy is similar to other major abdominal surgeries. Again, they would be anesthesia risk. You have to have some type of anesthesia, obviously, with these procedures. Bleeding is always a risk with any type of major surgery. Infection, injury to bladder, bowel, structures in the pelvis that are in close proximity to the uterine and ovarian structures. When a patient goes home, generally after surgery, we're initially looking to make sure there's no issues with bleeding, make sure there's no initial problems with fever, making sure there's no incisional problems. And when we send a patient home, generally at that time, she's voiding well, tolerating a regular diet. When she goes home, rest is important for the first several weeks. We have her back to driving 10 to 14 days after her surgery. What she should be looking for is to make sure she doesn't have any significant temp, by that anything 101, or any problems with incision, with redness, hardness of her incision, drainage, anything of concern. We just would like for the patient to come in so she could be examined.
Okay, all right. Well, I think we've covered a lot of material here, and I think we've covered just about everything that I have a question about here. Do you have any other questions that you commonly hear of related hysterectomy? One question that I might want to wrap up with: if a woman is reluctant to have a hysterectomy, does she have any other options? Or
that's one of the most important things, I think, that in counseling a patient prior to surgery, there are a lot of options out there, and it's important for a patient to feel like that she has really explored all of her options before she has to go under any type of surgery, because any surgery, no matter how minimally invasive, is still a major ordeal. So when you're talking about uterine fibroids, there are medications out there that can temporarily decrease the size of fibroids. There have been some radiological procedures where some fibroids may be shrunk or eliminated. When you're talking about endometriosis, there are medications out there that can be used for pain. Obviously, people have a lot of medical options, birth control pills to help regulate cycles. There are some other minimally invasive surgical procedures for people whose main complaint is just heavy bleeding, such as an endometrial ablation. So there are a lot of options. I think it's really important that patients come to me, and they need to be ready to have a hysterectomy. It's not something where there are certain situations where we would really encourage a patient to have her uterus removed if she had some type of malignancy or something of real urgent concern. Mm-hmm. But most of the time, this is what we call a, quote, elective procedure, because the patient does have time to look at all of her different options, explore those options before she decides to have her uterus removed.
Great to have options.
Right, absolutely.
Well, thank you so much, Dr. Wooley, for all this great information. It's a very common procedure for a lot of women, and it's great to know all the information you've given us, and especially that there are more options. And for our viewers, I just want to let you know that if you are in that phase when you may be considering a hysterectomy and you need more information about it, Dr. Wooley is going to be doing a free community seminar that's going to be on February 25th at 11:45 here at the Baptist for Women Conference Center. There's an optional $5 lunch available for that. If you want to pre-register, you can pre-register by calling our Baptist Health Line at 601-948-6262 or toll-free 1-800-948-6262, or you can register online at www.mbhs.org/classes. So be sure and check that out. Dr. Wooley will be available, and we'll have great information there, and I'm sure we'll take questions from the audience at that time. So thank you so much for joining us for our webcast today. Thank you, Dr. Wooley, for coming with this great information. We want to encourage you to tune in next month. Our guest speaker is going to be psychologist Bufkin Moore. He's going to be talking about finding hope during cancer treatment, and that will be on February 9th. So please, particularly if you're in treatment for cancer or know someone who is in treatment for cancer, that's a great topic not to miss. So mark it on your calendar, and please plan to tune back in. Thank you for joining us.